Good morning, everybody. Today our topic is transesophageal echocardiography, the basic views. We'll be sticking to only the way we detect congenital heart disease and not adult. First and foremost, the most important understanding is whenever we consider a transesophageal echo, we need to make sure that we have a transthoracic echo done with a complete understanding, and then only TE is considered with a problem-oriented approach. So when do we consider transesophageal echo? One is when the quality of transthoracic echo is poor, or sometimes transthoracic windows are impeded. The quality of transthoracic echo is poor in situations where the patient is an older patient, or we have prostatic valves, or we have thoracic deformities like chest deformity, kyphoscoliosis. Children who have undergone Fleming's, Fontaine's, and conduits as they grow older in second and third decade, transthoracic echo may not be sufficient. And then in endocarditis, the pickup of vegetations is much more sharper and more sensitive on transesophageal than transthoracic. Windows are commonly impeded in situations where the baby is in the operating room, or in the cath lab, or in the ICU. So with this understanding, we know that transesophageal echo is performed either in the cath lab, or in the perioperative period in the operating room, or in the post-op cardiac ICU, or sometimes in the cath lab. Major contraindications are usually any issues with the esophagus in terms of bleeding, perforation, or unrepaired tracheoesophageal fistula, or if the child is not in a compensated state, or we have any issues with the cervical spine, or we have altered clotting factors. How do we prepare a child? This is most important on OPD basis, especially for ASDs in children when we consider transesophageal echo. The child has to be NPO for at least 4 hours. Counseling of the patient in terms of explaining the procedure is very important to get cooperation. Examine the mouth for any loose teeth, and put the ECG leads, blood pressure and pulse oximeter. Have an IV access standby, and also keep a resuscitation cart standby. Now with this understanding, the child is given either a spray or viscous gargles at least 30 minutes before the procedure. A light sedation could be considered in children where we do not expect enough cooperation. Now what is different? Is transesophageal echo different in children compared to adults? Apart from the consideration of the size of the probes, whether we would consider a pediatric probe or an adult-sized probe, the most important is that if you're using a jelly instead of a spray, we should not use it in an excessive amount. Do not force the probe. Whenever we are manipulating the probe, do not forcefully move the probe. Limit the degree of flexion, whether it is anti-flexion or retroflexion or lateral flexion. And also that when we are not using it, especially in the operation theatre, put it on a freeze mode. Do not continuously keep it on mode even when it is not used. So with this understanding, we have certain general principles for transesophageal echo. Either we start with the structure in question. So whenever at the end of a transthoracic echo, we know what questions we have, either we start with that structure in question, or else we rapidly advance the probe till the stomach and then withdraw. So we could start at the transgastric level and then withdraw the probe slowly. The depth markers are definitely the way to guide in adults. However, in younger babies, it may not work for us. So watching the image can tell us where we are. A comprehensive examination may not always be feasible. Also that the orientation, we will go as we go through the images, how to understand the orientation. But remember that the apical structures are on the left side of the screen. And try to do 2D and color once one image is over at a time. So now here we can see that there are few movements which we can do with the transesophageal probe. One is that we can withdraw the probe or advance the probe. So this is what we initially saw, that either we advance the probe till the level of stomach and then gradually withdraw, or we can go with the structure in question. The second movement is the manual movement with the hand, where we can turn the probe manually to the right or to the left. The next one is what is there already given in the probe in a way to manipulate in terms of anti-flexion or retroflexion. Anti-flexion means we are putting the probe more in, or we can do a flexion little to the right or left. And the last, which is the most important, is the axial rotation. The axial rotation, it rotates from 0 to 180 degrees, and you can come back from 180 degrees to 0 degrees. So whenever a probe is put like this here, we either go at the level of stomach, and then it is going to have a section cut like this. So the beam is going to pass like this. These are the posterior structures, and these are the anterior structures. When we go to the mid-esophageal view, and this is what it is going to cut the heart as, where we get a typical 4-chambered heart or a cut across the long axis of the heart. And then when we withdraw the probe a little more, this becomes the basal view, and the basal view is more related to the great arteries or the base of the heart. So as we can see in this figure, the first one is the transgastric, where it cuts in across the axial axis, across the axial section, and this is what we get in terms of a cross section of the left ventricle and the right ventricle. When we withdraw the probe a little more and come to the mid-esophageal, the first was the transgastric, the second is the mid-esophageal. At the mid-esophageal view, what we start as is the typical 4-chamber view, and with deflection we go a little posterior or anterior. And between the mid-esophageal and the short axis basal, there are a couple of views in between which we will go through. And as we come a little more withdrawn to the basal short axis, we get the cut sections of the aorta and the pulmonary artery, or even the aortic arch. Now coming back to the last movement, which is across the axis, axial rotation from 0 to 180 degrees, we have to understand that when it is at 0 degrees, the patient's right is on the screen right. So the right sided structures are on the right, the left sided structures are on the left. And as we rotate to 180 degrees, it exactly becomes the opposite. The screen left is patient right, and the screen right is patient left. I think with this understanding, we can see further that we have multiple images in multiple levels, and we start with the transgastric. Now in an older patient, this holds true. By the time you put the probe up to 40 to 45 centimeters, what we will get is a transgastric view. A little pushing further is the deep transgastric. The deep transgastric has a special importance on pediatric side. We will see a couple of slides further. The transgastric view, we put it at 0 degrees. Now remember, every manipulation has to be done with the probe preferably in 0 degrees, and that means it's a neutral position. A little anti-flexion get the close proximity with the heart. What we see in transgastric view is a cross section of the left ventricle and the right ventricle. So at the usual transgastric, we will see the left ventricle level. The one towards this is the posterior aspect, and this is the anterior. This is close to the probe, hence this is the posterior, this is the anterior. This is the medial, and this is the at degrees. Where we have a cross section and we add 90 degrees, a short axis is going to become a long axis. So adding further 90 degrees, what we will see is the long axis of the left ventricle. The long axis of the left ventricle with its papillary muscle. As we see, this is the posteromedial papillary muscle closer to the probe, and this is the anterolateral papillary muscle. So from the short axis, we get a typical 2-chambered heart, the left atrium and the left ventricle. And a little further by 120 degrees, we open up the aorta. So this is sort of a long axis of the LV outflow tract. However, these views are less commonly used for LV outflow tract. Now going to this mid-short axis and Pulling the probe a little further, what we will get is a cut section at the level of mitral valve. This is again 0 degrees, and the mitral valve, anterior mitral leaflet and the posterior mitral leaflet will be seen in this orientation. Now, in this we have 3 scallops as we understand, from the lateral to the medial aspects named A1, A2, A3 or P1, P2, P3. The commissure, which is situated on this side, is the anterolateral commissure, and the other one is the posteromedial commissure. So the posteromedial commissure and the anterolateral commissure. So we can understand this is medial, this is lateral, this is posterior, and this is anterior. This understanding of the scallops is important because, as we will see, as we rotate from 0 degrees to 120 degrees to 90 degrees, we will see how it cuts different scallops of the anterior and the posterior leaflets. So what we saw so far is a basal short axis and 90 degree in addition to that. Now in the same position, along the long axis, if we rotate it towards the right side, what we will open up is the right ventricular inflow. So what we get is right atrium and right ventricle with the tricuspid valve having an understanding clearly about the leaflets at almost the same degree, around 120 degrees. Putting the probe a little further, advancing the probe a little further at approximately 45 centimeters, we get the deep transgastric. Remember, all these movements are done once we go back to 0 degrees. So the deep transgastric view will show the left ventricle and the right ventricle and open up the left ventricular outflow tract beautifully. This is one view on TPE which can give us good left ventricular outflow Dopplers, and a little rotation on the right side, the right ventricular outflow can also open up. So to get the Dopplers, the transgastric view is needed because there are no other views in transesophageal echo where we can get LV or RV outflow gradients. So now this is all about the transgastric. We just run through it once again. The transgastric view come to 0 degrees and anti-flex the probe. What we will get is a short axis of 2 papillary muscle, a little withdrawal is the short axis at the level of papillary muscle, add 90 degrees axial rotation, a long axis of LA, LV and LVOT, turn towards the right and RA and RV, inflow of the RV, and then come back to 0 degrees, advance the probe a little further, and what we get is the left ventricular outflow tract and sometimes even the right ventricular outflow tract. So this is what we see in transgastric view. A little withdrawal of the probe, and what we will get is the mid-esophageal view. In older children, it will come around between 30 and 40 centimeters. So the mid-esophageal, as soon as we come to the mid-esophageal view, we will see a very familiar view, which is like a 4-chamber apical view on transthoracic. What we get on the right side of the screen are the right-sided structures, and the left-sided structures are on the left side of the screen. So at 0 degrees, what we see is the left atrium, the right atrium, and the interatrial septum. The atrial septal defect with the mitral rim can be well seen in this view. Also that if we turn the probe and advance the probe a little to the left and the right, corresponding pulmonary veins can be seen. Coming down the AV valves morphology, the interventricular septum, the inlet area just below the AV valves, and the rest is the trabecular septum, the right ventricle and the left ventricle. Now what we see here on the right side tricuspid valve is going to be the septal leaflet and the posterior tricuspid leaflet. Now the mitral leaflet are cut in this way. Why is it that it's A3 and P1? We will go through this picture. Now as we know, we are at 0 to 20 degrees of a 4-chamber view. So this is how it's cutting its section, and we can see that it cuts. As we saw before, this is A1, A2, A3, and this is P1, P2, P3. So it cuts the A3 and P1 in an actual section. A little retroflexion. As we said that there were two movements, anti and retro. The anti-flexion is going to give a little more anterior tilt, and retro is going to give a little more posterior tilt, and what we will see is the coronary sinus in a posterior tilt or retroflexion. And when we come anteriorly a little further, we will be able to open up the left ventricular outflow tract. This view is very important to decide on the crux of the septum, make sure that we have an offset and that it's not a common AV valve. Now from the four-chamber view, we are going to now turn a little further towards 60 degrees and 90 degrees, where we are going to get the two-chamber view and the long axis of the heart. So this is how the axial rotation is going to make a difference in the cuts. So from the four-chamber view, if we put another additional 60 degrees, we are going to get a two-chamber view, which involves the left atrium and the left ventricle. And again, how it cuts the mitral scalops is in a different way, where it looks like this is the opening, but no, these are the commissures and these are the leaflets of the mitral valve. This view is important especially for the left atrial appendage in older people. So the mitral commissural view is the LA, LV and the mitral valve, different components of leaflets at 60 degrees. Adding a little further at around 90 degrees, what we get is a two-chamber view, which is again LA and LV, but here we are having the leaflets which are different from the four-chamber view, which is A1 and P3, and we still see the left atrial appendage. So as we saw, this was the four-chamber view. The mitral commissural view comes somewhere in between, and the two-chamber view comes at approximately 90 degrees. So this is all done when we start with the mid-esophageal view. Now, going a little further at 120 degrees, it will become a long axis of the heart. So it cuts across the left atrium, left ventricle, and left ventricular outflow tract. So in this view, what we see is the A2 and the P2. The anterior mitral leaflet is the leaflet which is closer to the aortic valve, and a part of the right ventricle can be seen with the interventricular septum in between. So the long axis comes at 120 degrees. Now with manual rotation, if we rotate towards the right side in a similar view, sometimes you might have to withdraw the probe a little bit and adjust it around 90 degrees. What we will get is a RV inflow-outflow view. So this view is important especially for children after telerad surgeries, and we see that this is the aortic valve in cross-section. And the tricuspid valve, the right atrium, the left atrium, and the right ventricular outflow tract with the pulmonary valve opens up well in the outflow view. Again, same relationship. This is posterior, this is anterior, this is medial, this is lateral. So the tricuspid leaflets are the same. Anterior and posterior tricuspid leaflets can be well seen in this view. The aortic valve has to be addressed, then we put the probe a little more further across the aortic valve short axis to concentrate there, same around 60 degrees. And the aortic valve having three cusps, the one which is in closer to the interatrial septum is the LCC and the MCC, and the other one which is close to the pulmonary valve is the RCC. So here this view is important to see this aortic valve morphology. Sometimes the coronaries across it, the interatrial septum and the tricuspid valve and the pulmonary valve. In this similar view, a further withdrawal is going to bring the right ventricular outflow and sometimes the branch pulmonary arteries. The RPA could be seen hugging the aorta. The left pulmonary artery sometimes goes out of the view. So this is the aortic valve, short axis. So we have withdrawn the probe a little, and it's the short axis of the aortic valve. Adding another 90 degrees at the aortic valve level, we will get a long axis. The aortic valve long axis view, this view is similar to the one which we felt in transgastric, but this view is preferred especially for the aorta, the supravalvular, the subvalvular issues, the aortomitral continuity, the mitral valve, and the outlet VSD, the subaortic VSD. So what we see here is the aortic valve, and the cusp which is closer to the anterior mitral leaflet is going to be the NCC or LCC. The other leaflet is the right coronary cusp. As we understand, this is posterior, this is anterior. The mitral valve morphology, the aortomitral continuity, subaortic membranes, the supravalvular aortic dilatation or narrowing, and the perimembranous or subaortic VSDs can be seen beautifully in this view. So this is the aortic valve long axis. So whenever we see the long axis, it's around 120 degrees, a little withdrawal of the probe. So it's going to be close to the aorta. The next structure on the right side is going to be the SVC. And here we can see just behind the aorta is going to be the interatrial septum. So then we shift to the bicaval view, which is around 90 degrees, and we might have to rotate the probe a little bit towards the right to open up the IVC and the SVC. So here we can see that the inferior, the structures which are close to the apex of the heart come on the right side of the screen. This one important message we saw when we started going through the views is that the apical structures come to the right side of the screen. The IVC is going to come to the right and the SVC is going to come to the left. The structure, the atrium, which is closer to the probe is going to be the left atrium, and this is going to be the right atrium. The interatrial septum can be beautifully viewed in this view, including the SVC and the IVC rims, and the right atrial appendage can be well seen in this view. Now the right upper pulmonary vein is just sitting across here, so a manual rotation of the probe to the right can open up the right sided upper and middle pulmonary veins, entering the left atrium. So this is the bicaval view, and then we withdraw the probe a little further because we were at the level of the aortic valve and the ascending aorta, and then we come a little further at the ascending aortic short axis. You come back to 0 degrees, and what we will see is an aortic short axis with SVC on the right side and the right pulmonary artery closer to the probe in its long axis. This view is similar to what we see in our transthoracic suprasternal view, where we see the right pulmonary artery and the ascending aorta. And making 90 degrees, we will bring the ascending aorta all across its length, and the pulmonary artery becomes a short axis. This is again the right pulmonary artery. The left pulmonary artery is going to be difficult to view even in this level. And so this is the ascending aorta, and a little further we can get the descending aorta. Actually, the descending aorta can be seen as a cross section in the 4-chambered mid-esophageal view. So it comes as a cross section behind the left atrium. So you can go back to the mid-esophageal 4-chamber view and then get the descending aorta in short axis, and that short axis of descending aorta will look like this. And all across, putting 90 degrees, we can see the long axis. So now this is all about all the mid-esophageal views. So we will run through it once again. The first one is at the 4-chamber view. A little posterior and anterior tilt can get the CS and the LV outflow tract. A turn towards the right and the left sometimes opens the pulmonary veins. Adding 60 degrees comes the mitral commissural view. Coming to 90 degrees, we get the 2-chambered view. At 120 degrees, we get a long axis of the heart. The long axis of the heart, manipulation towards the right, we get the RV inflow and the outflow. Coming back to aortic valve, short axis at 60 degrees, we get the aortic valve short axis. Adding 90 degrees, aortic valve long axis, and then coming to the bicaval view. And then going to the ascending and the descending aorta. The last is the upper esophageal view, which comes at approximately 20 to 25 centimeters. These last couple of views are practically more used by adults and less used on the pediatric side. Now here we have only one view which shows the aortic arch, where we get the aortic arch in its long axis at 0 degrees, and when we turn 90 degrees, we get aortic valve in short axis. Here we can see that from the mid-esophageal RV outflow view, where we could have seen the right kidney artery. On the right is going to be the ascending aorta and the aortic arch. So this completes all the views, the transgastric, the mid-esophageal, and the upper esophageal. At every view, we need to do the 2D and the color and keep thinking about what structures we need to double check at all levels. Do not forget the Doppler examination, and at that particular point in time, we have to understand that the alignment sometimes gets difficult. The 4-chamber view is okay for AV valve regurgitation, taking tricuspid valve jets. The LV outflow is practically more better taken in transgastric. RV outflow tract sometimes gets difficult. Sometimes transgastric and sometimes alignments are not possible ideally. And also remember that there is a difference between the Dopplers done transthoracic and transesophageal, especially because inside the operation theater, the hemodynamic conditions might alter the gradients what we are getting, and the jets may appear a little bigger than what they are. Common indications on the pediatric side for transesophageal echo would include, on OPD basis, especially the atrial septal defect, and intraoperatively it's commonly used for LV outflow tracts, atrioventricular septal defects, the ventricular septal defects, and sometimes endocarditis and abscess in the postoperative scenario. Operated congenital heart disease definitely after sending spontans, older people, especially to check for clots in the appendages, etc. Transesophageal echo is commonly used. Now, if complications are very rare, if basic precautions are taken, and sometimes it can actually compress the bronchus, the descending aorta, etc., or sometimes cause airway obstruction. Other than that, complications are very rare, and it's a safe procedure. But though it is safe, it is semi-invasive. So always remember that we need to justify the need for transesophageal echo. Make sure the probe size is correct. The probe manipulation, as we say, should be minimal, and we need to remember that transesophageal echo is not a substitute for comprehensive transthoracic echo. So now, having understood all the basic views, anybody has any questions? Otherwise, we'll go to the just a few questions from my side. Any questions? So if there are no questions, we will see what are the views for an atrial septal defect. What common views do we take for an atrial septal defect? Yes, so it's mid-esophageal 0 degrees for the mitral rim and the size of ASD. 30 to 60 degrees brings the short axis of the aorta for the aortic rim, and 70 to 120 is the bicameral. So that's right. So we have the mid-esophageal 4th chamber, the aortic valve short axis, and the mid-esophageal bicameral. That's right. Now, what are the common views we use for atrioventricular septal defects? The atrioventricular septal defect commonly is a scenario where perioperative TE is considered, especially initially pre-op to find out the type of an atrioventricular septal defect, the size of the interventricular communication, the amount of atrioventricular regurgitation, the cause for regurgitation, the surgical strategies to be considered for the type of repair of an AV valve, and then post-operatively to find out the residual regurgitation, PA pressures, the residual shunts, etc. So this is a scenario which is commonly there with us in a perioperative stage. Anybody, what are the common views for atrioventricular septal defect? Yes, so it's mid-esophageal 0 degrees, 60 and 90 degrees. To open up the different components of the mitral valve, 120 degrees is to assess the atrial septum. Okay, I would say 120 degrees, 60, 90 and 120 degrees would be probably to assess the mitral valve in different segments, the AV valves and the LVOT. Okay, so mid-esophageal 4-chamber view, the 2-chamber, the long axis, and what we also have to remember is the transgastric basal short axis view, where we actually get the mitral and the tricuspid valve as a short axis. You could demonstrate the cleft, you could demonstrate the site of regurgitation, the number of papillary muscles, etc. Yes, so for the left ventricular outflow tract, we would probably consider the long axis. If no gradient, then we do not have to go to the transgastric. That's right. Now, what are the views for LV outflow tract? So left ventricular outflow tract in pediatrics, if we think about it, we commonly use it for subaortic membranes, the aortic valve abnormalities in terms of stenosis or regurgitation, to see the site morphology of aortic valve, and supravalvular issues. Also for perimembranous subaortic VSDs we use it, but for the left ventricular anomalies, we commonly use mid-esophageal 90 to 120, that's right. The additional important view will be the transgastric long axis for getting the gradient, as we saw, yes, deep transgastric 20 degrees. And here we have, okay, I think the deep transgastric 20 degrees is going to give us the short axis of the ventricles, but you put additional 90 degrees, so it comes to around 100 to 120 degrees, we'll get a long axis view. And what are the views for VSDs? So we commonly see that post-operatively for residual VSDs, we do a post-op TE. So based on the position, we will have to think of all the sections where we will get ventricular septal defects. Yes, so the VSD is mid-esophageal 120 for perimembranous VSDs. That's right. That's right. For perimembranous VSDs, we can use the mid-esophageal long axis. Across 120 degrees, the membrane is defect. Also remember that when we put it in short axis across the aortic valve, we are going to see the membranous defects close to the tricuspid valve. So for perimembranous defects, we can use mid-esophageal 120 and also the aortic valve short axis view. Yes, so mid-esophageal for inlet VSDs, long axis of aorta for subaortic, degree for perimembranous ventricular. That's right. So what we see is we will start with individual views and see that the mid-esophageal, transgastric for muscular VSDs, that's so much true. Because muscular VSDs sometimes what we see in the 4-chamber view would be only the posterior muscular VSDs. The anterior ones we commonly miss. So for that, the deep transgastric view would be definitely useful. So the mid-esophageal 4-chamber view will give us the inlet VSD, the mid and the lower VSDs in the muscular septum, and also the apical VSDs. When we go to the aortic valve short axis, we will see the membranous defect and even the outlet VSDs. In the long axis view, we will see the perimembranous outlet VSDs and also the rest of the muscular VSDs which are at the level of aortic valve. And then the transgastric base and short axis view, we will see the anterior, mid and posterior VSDs at a particular level. If you are having a transgastric cut at the AV valve, we will also see the inlet VSD. So I think that's right, and we probably would end up our talk today. Any questions?